So, okay, without further ado, Tara Mays. Tara, no stranger to this committee. Welcome to committee.
Good afternoon, Mr. Chairman and everyone, members of the committee. I am Tara Mays from the Kansas Hospital Association. Appreciate the opportunity to appear before you today and provide a little bit of background information. I thought what might be most helpful for you all this afternoon is to give a little bit of an overview of who we are at the Kansas Hospital Association, why what we do is important to you and your communities and constituents from around the state, and then how we can work together in 2025 during the legislative session. And then we'll leave some times for any questions that you all might have, and we're happy to answer those, although I'll commit that if I don't know the answer, I'm happy to get it for you at an appropriate time. Appreciate the opportunity again to be here. Wanted to provide you, like I mentioned, a little bit of background information. Oh, let's see, how does this work? Can you show me? Ooh, fantastic. Wanted to provide you a little bit of information about who we are as an association. So we are a membership organization. Although I have not been around since 1910, the association has been around since 1910, helping to develop solutions to assist Kansas communities. Our goals and vision really lie around keeping hospitals healthy so that we can continue to serve you and your constituents and patients across the state of Kansas. So, what makes up the Hospital Association? So in Kansas, we at the association represent 121 community hospitals. Those include 82 critical access hospitals, 18 healthcare organizations, 2 military and veterans hospitals, 17 hospital systems, and then 15 hospital networks. And so you have in here kind of a graphic of all those and how many licensed beds are in each county across the state of Kansas. So I thought what might be helpful for you all today is to talk a little bit about some of the hospitals that there are, how they're licensed, and how this operates. And so you do have a reference guide that I believe was provided that has a spiral binder. And I'll just tell you, I know we use a lot of acronyms at the Hospital Association and probably in this committee throughout the course of your work. And so we hope that that information will be a helpful tool to you all to be able to look at why are we saying these acronyms and what do they mean? Although I will try very hard to refrain from using acronyms for the purpose of today's presentation. There are certain types of hospitals throughout the state of Kansas in terms of how they are designated, licensed, and how they are discussed in the state of Kansas. So we have critical access hospitals. Again, there are 82 critical access hospitals that we represent. Those are limited service, largely rural, not-for-profit, or public hospitals. They provide mostly outpatient and some short-term inpatient hospital care on kind of an urgent or emergency basis. Then there are prospective payment system hospitals. Those are usually a little larger than the critical access hospitals. Providers are paid for services to patients with rates that are established in advance or contracted in terms of the upcoming fiscal year. There are also teaching hospitals. Those are hospitals that have accredited physician residency training programs. They are typically affiliated with a medical school in the state of Kansas. We also have specialty hospitals. Specialty hospitals are hospitals that provide kind of a limited or more narrow range of services. Things like orthopedics, ophthalmology, obstetrics, those sorts of hospitals are what we would consider specialty hospitals. And then the newest of all of the hospital types in the state of Kansas are rural emergency hospitals. You might hear me talk about them as REHs, but what those are is they are essentially a hospital that provides emergency stabilization services, but they do not have standard inpatient beds. In the state of Kansas, we do have 3 rural emergency hospitals. They've just been allowed within the last, I think in 2021 was when we passed the state statute. We were the first state, not to brag, but we were the first state to pass state statutes to allow a hospital to transition to a rural emergency hospital. The 3 in our state, the first one was Ark City is a rural emergency hospital, La Crosse, Kansas is a rural emergency hospital, and the most recent one is Mercy Hospital in Mound Ridge, Kansas. So those are our 3 rural emergency hospitals in the state of Kansas. Now, I mentioned to you a little bit about talking about what it is that we do and how that really kind of connects to you and your communities and your constituents back home. Our hospitals and healthcare as an industry really are the third largest employer in the entire state of Kansas. 73,000 Kansans are employed by hospitals in the state of Kansas. Of every 100 hospital jobs, there are 72 kind of components that actually produce 72 non-healthcare jobs in different sectors of employment in the economy. So largely that creates about 300,000 jobs annually in the state of Kansas that produce $21 billion in labor income in the state of Kansas. So our hospitals really are considered a community asset, and we know that we are a driving sector of the state economy, and we take that very seriously. So that's a little bit about why we're kind of connected to you and your communities. Now I'd like to talk a little bit, shift gears, about some of the ways that we are interested in working with you all in the upcoming 2025 legislative session. There are three main areas where we hear from our hospitals that we need to focus on, three major areas of concern right now. And I'd like to dig a little bit deeper into each of these. One is hospital finance and the health of our hospitals across the state. Another one of those is patients' access to care, being sure that patients can get the right access to the right care at the right time. And then obviously, not unlike many other sectors, workforce challenges continue to plague the healthcare industry. So, to dig a little deeper into each of those, it's no secret that in the state of Kansas, we have an aging population. And as the state of Kansas population ages, the costs of care for those aging Kansans also continues to increase. In the hospital sector, our supply and labor costs are up more than 35% over the last few years. Home-based and community outpatient services continue to grow as the population ages. And so technology companies and the need for technology innovations are continuing to be and play a greater role in our ability to provide solutions for patients and to extend our workforce to be able to provide the right care at the right time. So what is that really producing? While our financial kind of impacts outside the hospital walls are felt within the hospitals. So right now in Kansas, we have 67% of our Kansas hospitals that have had a negative operating margin going into 2024. As this committee may remember, last year, that's actually down from last year when we were at 73% of our Kansas hospitals that had a negative operating margin. So we're doing a little bit better. Still, unfortunately, above that 50% threshold of hospitals with a negative operating margin. We look really nationally at a statistic that is called cash on hand. And that metric really allows us to know what do hospitals have to invest in services that their communities might need. Nationally, hospitals have an average of cash on hand of about 265 days cash on hand. In the state of Kansas right now, on average, our hospitals have about 62 days cash on hand. So unfortunately, that metric isn't probably where we would like it to be. Recently, at the Hospital Association, KHA, we administered a study through a private consultant to show, to really answer a question. We were hearing from a lot of hospital administrators, nurses that have worked outside of the state of Kansas and coming into the state of Kansas that things look a little differently in some of our surrounding states. States like Nebraska, Oklahoma, Missouri. And so we wanted to find out a little bit more, are hospitals healthier in those surrounding states, or is this a perception? So we used a consultant to do an economic study, and what they found was that in Kansas, compared to our surrounding state hospitals, we have about twice as many hospitals that are medium to high risk financially compared to our surrounding states. So to highlight, those are really you might ask yourself, well, is that, Tara, because we have more hospitals? than the surrounding states. We have some data that shows that based on our population, it's really about exactly the same in terms of the number of hospital beds and our population here in the state of Kansas. So what are some things that we could work on together to really improve that financial situation for our hospitals? We have some ideas of things that we might be able to work with you all on. The provider assessment is a very, very important component for our hospitals to be able to draw down federal funds and disperse those funds amongst ourselves to keep us financially healthy. So we'll be asking you all to look at putting that permanently in state statute. So this committee may have some conversations around the provider assessment. We need to continue to build on the outpatient Medicaid rate increases that you all put in the budget last year. Those have been very, very helpful to our hospitals. You all did a tremendous job on that. And so we really appreciate that. We think there's some more work that really needs to be done to get us in alignment with some of those surrounding states and their Medicaid rates. We also know that our hospitals have continued to see losses in some of the services that your constituents need the most. So when I'm talking about those lines of services that tend to be loss leaders for our hospitals, I'm talking about things like behavioral health, and I'm talking about things like maternity care. Those tend to be the biggest loss leads for hospitals. And so when we look at, like any good business, we look at, what is our loss leads and what should we be looking at cutting? Those tend to be some of the focus discussions. So the add-on payment that you all allowed for behavioral health beds last year, there was an add-on payment for behavioral health, and that helped hospitals continue services for those behavioral health beds, particularly in a season when I know you all are investing in a new state hospital in the South Central region. And so we would like to continue to see some of those behavioral health investments. Also, the Rural Innovation Grant Program, you all passed as a part of the Rural Emergency Hospital, or REH designation, a grant program that allowed our hospitals to be able to get grants to do that transition to a rural emergency hospital. Unfortunately, that is not in any of the budget proposals that are before you at this point in time, so we would love to find a way that we could continue the Rural Innovation Grant Program. In addition, the Rural Emergency Hospital Program, as I mentioned, is the newest of the designation of hospitals. And I also mentioned to you all that Mercy Mound Ridge is the last of the hospitals to transition. Unfortunately, when they did that transition, they found out that they were not going to be able to be licensed through KDADS as an existing service with their swing bed services. So those services are really designed for patients that are probably older or having complex surgeries out of where they live, and they're trying to recover closer to home, truly. So their stays are usually pretty limited, probably a few weeks while they do some therapies at home. And so Mound Ridge Hospital had been operating swing beds or skilled nursing facility beds for a period of time. And when they transitioned to the Rural Emergency Hospital Program, the agency, KDADS, told them that they would have to be licensed as if they were a brand new facility, which would have required them to make about $3 million worth of upgrades to their facilities. So we are interested in having a conversation with this committee about how we can encourage KDADS statutorily to seek a waiver so that those rural emergency hospitals that have skilled nursing facility beds can be able to keep that service in their community. On to patient access to care. We have, as you might imagine, a lot of uncompensated care in the state of Kansas. About $2.1 billion in the last survey that we did. And while we sometimes think of uncompensated care as those that don't have insurance coming into emergency rooms, it is also a lot of other things. It is sometimes a payment that's been denied by a payer, and I'm going to just qualify what a payer is really quickly. We consider a payer one of the people that are covered by Medicaid, so those state services, those folks that are on state services through the Medicaid program, Medicare, which is more of the federal side of government, and they have a Medicare plan, or a commercial payer. So someone that has insurance, they've either gone to the exchange to get insurance, or they have insurance through their employer. Those are the three kind of main payers that we see. So if a payer is when we kind of look at our financial analysis on Medicaid payers, we lose about 5.3% of what it costs us to serve that patient. On Medicare, on average, we're losing about, I'm sorry, I said that wrong. On Medicare, the loss is about 5.3%. On Medicaid, the loss is about 1.83%. So that's what we lose on Medicaid payments. And largely what we make up is in commercial payers. And we get about, sometimes it's close to plus 0.90 on average. So as you might imagine, those numbers don't add up to a financial healthy reality. So we have to use some other programs really to be able to ensure that we can make ends meet and that we can provide services to Kansans that are vulnerable. And certainly programs like 340B and protecting that program is really important in the state of Kansas. Things like really being able to address getting patients the right care at the right time through reform in the prior authorization process and the speeding up of that process, as well as being able to address things like patient transfer issues. We're dealing and hearing more and more from our hospitals about the inability to get patients from a higher acuity setting to a lower acuity setting for a variety of different reasons. So whether that's a way to look at the state statutes around guardianship and how we can improve that process, or how we can get patients to a lower acuity, more appropriate care setting at the right time, we feel like there's a lot of opportunity there to work with you on that. And to do a deeper dive into the last subject here, which is workforce, I will turn it over to my colleague, Jaron Caffrey, to talk a little bit about the current workforce landscape.
Thank you, Tara. And yeah, good afternoon, members of the committee. My name is Jaron Caffrey. If I've not had the opportunity to meet you, I lead our workforce and some other issues on behalf of the association and our hospitals. And so wanted to dive into this. Workforce is last for a few reasons, largely because a lot of these issues that Tara had just covered do factor into what does the healthcare workforce landscape look like. And so level setting a little bit and then sharing some potential opportunities as well, we'll follow that same theme. You can see in your packet here a few of the issues that really highlight what this looks like in Kansas when we talk about the healthcare workforce shortage. On the more of the physician side, you'll notice that over 70% of Kansas counties are what we call a health professional shortage area on primary care. You'll see there a map of where those counties are at, and that can change a little year to year. Workplace violence is an issue in healthcare that we've continued to deal with, unfortunately. It's not just patients, it's family members, it's people coming in off the streets, or it can be. And you'll notice there, healthcare workers are actually 5 times more likely to experience workplace violence compared to workers in other industries. So that results in time away from work, it results from burnout, and again, that contributes certainly to those who might come in or leave their places of work. And then you'll also see there that the chart is a little hard to read, but what that shows you is when we look at the year before the pandemic to where we're at today, the vacancy rate, AKA the number of jobs that go open or are open within hospitals throughout the state of Kansas, is still more than double than what it was in more of a normal year, quote unquote. And so that's really some of the when we look at what are the numbers when we're seeing this, that's really that gap that we're experiencing. You might get a better look in your packet at some of this, but you'll notice throughout the state of Kansas, this is a problem that most areas face. It's not an urban, it's not a rural problem. There is certainly shortages across the board in many healthcare occupations. And you'll see that there, the grapho on the right-hand side puts into context when we look at nursing, nursing being the biggest group of clinicians outside of more of the physician role that our hospitals employ. And you'll notice again when we look at compared to the pre-pandemic levels, especially that top, those percentages, when we again look at vacancy rates, well above what this was looking at pre-pandemic. And so the challenges continue to persist. They've gotten a little bit better the last year or two, but it's certainly a long ways to go to really get our healthcare system back at full capacity when we're looking at the workforce side. So here you'll see some of the themes, and we'll dive into a few of these more specifically. We've had the great opportunity to work with our KHA Workforce Committee over the past year, and that was really kicked off in the last legislative session. There was a subcommittee from House Appropriations that looked at initially issues facing contract labor in healthcare. But certainly as we had discussions over a week of that hearing, it certainly kind of, I think, folks really realized, we're paying money for agency staffing, and that's a symptom of the overall problems that we really need to address if we don't want to be paying some of those rates for staffing companies, both from the state hospitals and certainly also from non-state hospitals. So we're looking at things like, we'd encourage the legislature and this committee to look into investments. How can we attract and retain the workforce? And then specifically, potential investments when it comes to physician and the nursing workforce, again, being core groups. But of course, there is a lot more to healthcare than doctors and nurses. And so we would encourage looking at allied health enhancements to help more students pursue allied health professions in the state. But then more importantly, we want them to stay. We want them to work in the state of Kansas once they've graduated, hopefully, from a Kansas college. Mentoring and preceptorship are issues that have come up in the past year or two that we think are on the horizon as well. Child care and housing are certainly elements, whether it's looking at the Rural Opportunity Zone program or other enhancements. Those are tangential issues, not just relevant to the healthcare workforce, but communities and industries across the state. And then lastly, improving the credentialing process, which we hope to have more information as we continue throughout this session. But that is an issue across the board when a hospital or other healthcare employer tries to bring on a provider, but go through the credentialing process. There are a lot of delays where it can take literally months for that new hired provider to actually be able to practice and then receive payment based on the care that they were providing. So getting a little more into specifics, one of these big themes that we'd encourage this committee to take a look at is really how can we grow the workforce and keep talent in Kansas? And a lot of that might relate more towards colleges and scholarships. So number one, Kansas has a great program called the Kansas Nursing Service Scholarship Program. It's been around for a number of years, and one gap that we've seen these last couple of years is part-time students that go to a nursing program are not eligible to receive a scholarship. And so we think an easy fix for that is, well, let's prorate that scholarship for a student getting their LPN or getting their RN. But again, they might not be a full-time student, but they're still progressing towards that. We think that they should be eligible to be able to have that scholarship, which, to remind you, that then is a service requirement in the state of Kansas following their graduation. That's been a great program, but one area there you'll see on that number 2 is when we look at allied health. So we're talking about the therapists, we're talking about social workers, lab techs, respiratory therapists. A lot of those roles do not have any kind of scholarship or a loan repayment program in Kansas. Several other states have begun doing that because allied health is increasing in need. Our hospitals often resort to international employment for those roles, and we work with the federal government closely on some other barriers with that. But we think that we should have opportunities in Kansas to, again, incentivize a Kansas student, get your education to become that laboratory technician, but then here's an extra incentive to stay working and serving Kansas communities. So we'd like to look at maybe a healthcare service scholarship program this session. And then number 3 there, a program specific to the schools of nursing in the state of Kansas. The past several years, for a number of years, there's been $1.8 million in the Kansas Nursing Initiative Grant Program, which that's been great, and we're using that as best as possible. The colleges are, that is. But that's divided amongst over 20 schools of nursing in the state of Kansas to buy things like simulation equipment or student success services. And so number 1, we'd like to look at a couple of those areas to direct the Board of Regents to potentially open up how colleges can use those funds, but also we need to increase the amount of funding to the Nursing Initiative Grant Program so schools of nursing can actually get appropriate resources to be able to have the simulation equipment needed to graduate more students from their nursing programs and then obviously keep them working in Kansas afterwards. And there's just a few other items going through this here, similar lines, but number 1 there, we'd like to see the creation of a healthcare upskilling and training grant program. Somewhat relevant to maybe conversations the last couple of years on apprenticeships in healthcare that we've really leaned into, but we continue to hear some instances where you don't always need an apprenticeship to do some of this more spot training, if you will, but there are gaps throughout the state in things like cross-training or certain programs where it might not make sense for a college to offer. And so we'd like to have a program like that for hospitals, long-term care, healthcare facilities overall, to be able to do some of that training to really extend the current workforce. Tara had mentioned the Rural Hospital Innovation Grant Program on the finance section, so I won't dive back into that, but that's certainly something that we see both workforce and financially related. The Rural Opportunity Zone program will need to be reauthorized soon, and so we'd encourage the legislature to, number one, we'd encourage it to be reauthorized, but we think this might make sense to take the time to look at the incentive categories. Maybe housing or childcare could be new incentives that are options of somebody that might take advantage of that program. And then lastly, we really would encourage the legislature to expand on the work that's happened the last year or two when it comes to workplace violence, and consider legislation to allow healthcare facilities to be able to press charges on behalf of their employees. Because unfortunately, a lot of employees, if you are assaulted, you might not want to press charges because that means you put your name out there. You have to pursue this. You have to relive this. And so a lot of other states have tried to remedy that and bridge that gap by allowing employers to do that on behalf of their employees. And so that's really where that's coming from on that front. And so I'll pass things back to Tara to close us.
Thank you, Jaron. You all have in your packet inside that binder that has our contact information. I would definitely encourage you to reach out to Jaron or myself or any of our staff anytime. We are happy to answer questions. After today, you also have a QR code that I've printed off in each of your booklets there. So if at any time you're interested in any of the data or the reports that KHA puts out, you can see that at any time. But Mr. Chairman, I'm happy to answer any questions.
Committee questions? Representative Reeves.
Tara, thank you so much for the presentation. It gets better and better every year. I love your slides. They're so good. Looking at slide number, I have no idea. It is the patient access to care and looking at the prior authorization piece. Are you hearing of any agencies that are using AI to do the prior authorization task?
You know, we've kind of talked with our workforce committee about, is there a role for AI in the obtaining of a prior authorization? The problem that we see right now is that there's not really a timeline on reciprocation for the prior authorization approval at this point if it's not considered in state statute a clean claim. So I mean, we're looking at it, but I don't know that it will solve all of the problems on the whole system.
Well, it's on the national scene right now, there seems to be some managed care organizations that are using AI, and it's not going well. That the rejection rate is, the denial rate is really high. So, but I didn't know if you had heard anything about that in Kansas, being done here in Kansas.
Thank you.
Representative Blex.
Thank you, Mr. Chair. Thank you, Tara and Jared, for your presentations. If I recall correctly, there was like, my numbers may not be exactly right, like 86 hospitals in Kansas, rural hospitals that was in trouble. And out of that, 59 or so, around 60 was day or tomorrow type thing. It's bad. But there was like 20 that was not in trouble. And the study that I think I read was the fact that they were smart enough not to get in debt, so they didn't have a big debt bill to pay off. And of course, reimbursements is a universal problem. Has that 18 or 20 that were in decent shape, or has that changed any in recent year or so?
I would say for our hospitals that are struggling based on the percentage of those that had a negative operating margin last year, that's improving now slightly. But I think there's not really been a change. Those that were healthy historically have probably continued to be okay without having some of the other complicated financial challenges related to some of those things that you mentioned, sir, like debt service.
Follow up. One other thing, it's kind of amazing to me, you didn't address this, and I know this is not your problem, but it's the time spent for certification, particularly for out-of-state healthcare providers to get a license. In my home county of Ford County, they've had a psychiatrist that's wanted to retire for 10 years, but had nobody to write prescriptions until Susan and I got the APRN bill. Thank you, Ms. Reese. So bottom line of it is, it's taken him 4 months to get his license from New York. And this is one problem I think is universal. We work constantly with compacts, nursing, it seems like Kansas is the only one smart enough to educate their people, and I don't believe that. You take somebody that's been in business for 20 years, it should be an automatic or fairly easy, but you didn't address that. Is that still a problem, or you?
Yeah, so the licensure piece of this is certainly something that we hear a lot about from our hospitals, but I think sometimes we think about it as if a physician or a healthcare provider that comes into the state of Kansas is going to be allowed to practice if only they had their license. And it's a much more complex process than that. And I think that's why in Jaron's slide, he mentioned the credentialing process. So there's the licensure process that we work on with the Board of Healing Arts process. And then there's this whole other side of things that happens on the back end where we have to provide a lot of information to each and every single one of those payers. And in the state of Kansas, last time I checked, there were somewhere around 66,000 insurance products sold in the state of Kansas for health insurance. So we have to submit all of that information to everybody that could possibly be a payer inside that provider system. And so the MCO contracts and the Department of Health and Environment have made a commitment to centralize the credentialing process for the MCO providers, but that is only MCO providers.
Thank you. Thank you, Mr. Chair.
Representative Ellis.
Thank you, Mr. Chairman. Medicaid reimbursement, is there any plan to increase that? I know that is terrible. Every time they get paid, they lose money.
Absolutely.
It needs to be at least break even.
Yeah. I appreciate the question, Mr. Chairman. I think the work that you all did last session was a step in the right direction, and we are hoping for an additional Medicaid rate increase on outpatient rates that I think could really help some of those kind of additionally struggling hospitals.
It would help a lot. Second question. The rural emergency hospitals, once you get in, you can't get out. It's like the mafia, isn't it?
Actually, I have good news. Once you become a rural emergency hospital, you are able to transition back to a critical access hospital.
At one time, you couldn't. And you're working on the swing bed?
Correct. We are hoping to have a bill in the legislature. In fact, there was just a bill introduced on the Senate side this morning to allow those skilled nursing facility beds that would be a part of a rural emergency hospital to have a waiver granted so that way they wouldn't have to be licensed as if they were a brand new facility.
That will help those 3 hospitals a lot because you get paid a lot for swing beds.
Absolutely. And,
Thank you.
And I appreciate the question because it not only will it help those 3 hospitals, but anybody looking at becoming a rural emergency hospital in the future will also be helped by some statutory remedy in that piece.
Thank you. Thank you, Mr. Chairman.
Representative Turner.
Thank you, Mr. Chairman. Thank you for the presentation. A couple of quick questions. So when you went through on slide 3 about the types of hospitals that are in your association, I guess I'll ask it the other way. What kind of hospitals aren't in your association? Are there any categorically, or do you cover?
I think we cover all types of hospitals, so I don't know that there would be any type of hospital. I can go back and ask if there's any, but I cannot think off the top of my head that there's any that aren't a part of our association.
Okay, so you cover pretty much every hospital if they choose to join your association.
Correct.
And the second question is you talk about the financial situation of hospitals, but in my area, it seems like we're building, expanding, there's urgent care facilities popping up all the time. So it seems like somebody must be profitable. Just wanted to get your comments about that.
Appreciate the opportunity. I think that there is 2 ways to think about financial struggles. Sometimes it looks like cutting services, and sometimes it looks like innovation and growth. And so as you see hospitals continue to grow lines of service, as we talk about kind of the need to be out in the community and providing more home-based care, you're going to see more innovation. And sometimes that looks like different buildings. And for some areas of the state, that can prove a helpful tool for that business to use to kind of grow themselves into a more successful model. But by and large, I would say that's not what you see all over the state.
Thank you, Mr. Chair.
Committee, further questions? Representative Winkle.
Thank you, Mr. Chairman, and thank you, Ms. Hayes and the Hospital Association for bringing this information today. I particularly appreciate that you brought some really concrete ideas about how to address many of the issues you're facing. It is noticeable to me that when you talk about finance, patient access, and workforce being key struggles in the hospital system, that Medicaid expansion is not at all part of the conversation today. So I just wondered if you could give us your very brief thoughts, especially given the comparisons to our neighboring states that you made that have all expanded Medicaid, like how that would be helpful, extremely briefly.
Yeah, thank you so much. I mean, I think I mentioned that we have $2.1 billion in uncompensated care, and I mentioned that uncompensated care comes from a variety of different ways. I think primarily we think about it of the people that walk into a hospital, that they don't have insurance, and we're required by federal law to serve them. And certainly, I think ideas like Medicaid expansion help to fill that gap when it comes to uncompensated care. It doesn't quite get to some of the other things that we're seeing more and more, so it's sort of a compounding effect. Like we have uncompensated care related to that, but a lot of other things too. So we believe that all of these ideas should be on the table in terms of being able to make Kansas hospitals more healthy and allow people access to get the right care at the right time.
Representative Stein.
Thank you, Mr. Chair. So back to that one slide about patients' access to care and reforming some of the prior authorization. So I know there are other states, and I know that's probably a big, umbrella, so to speak. I mean, that might be several things that they're doing to reduce that. Because as we've heard, I'm sure some of us, that's a big problem, right? We have a lot of our healthcare providers spending a lot of time on telephones trying to get prior auths, then maybe getting denial.
Any state has a perfect answer. I think states are trying very hard to be creative with how they find solutions in terms of prior authorization, and it's something that we'd definitely be interested in, but I can get you a table with some of the things that we've read about other states doing, if that'd be helpful.
Committee, further questions? Tara, I just have one. On slide 10, when you were talking about patients access to care, you made a couple of comments on like a 1% and some, it's not on your slide. So could you?
Repeat those?
Yes, please.
Yes, I'd be happy to. So our loss on average on a Medicare, kind of overall, our Medicare patients, we lose about 5.3%. On Medicaid, we lose about 1.83%. So on average, almost just a little under 2%. And then I also mentioned commercial payers, which is a plus 0.9% on average.
Are you sure you don't have those turned around?
I don't have them turned around this time.
Okay. So you lose more money on Medicare than you do on Medicaid?
That's correct.
Really? Okay. Thank you. Representative Reeves.
Tara, is that the Medicare loss? Is that because of Medicare Advantage plans?
The Medicare Advantage plans certainly have been a part of that additional loss. I think it's really changed over the years, and I think we've all thought that Medicare is a better payer, traditionally speaking, but what we've seen in the last few years, the economic conditions have just really shifted.
And I might add with Medicare sequestration, that's one of the items on the federal level that unless it's delayed year to year, there's usually a 2% cut on Medicare funding each year. So that also contributes to the decline.
Very good. Well, that was news to me. So, yeah, I've always heard, and Representative Ellis was, referencing our Medicaid, payments, which we raised by 9% last year, but you're still losing more money on Medicare. That's really wild. Very good. Committee, further questions? Last chance. Representative Bryce.
Thank you, Mr. Chair. Thank you, Ms. Mays. Good job. Just on that same question of Medicare and Medicaid, how much was lost? Is that including inpatient and outpatient for the hospitals? The hospital, we seem to be talking about them as not just inpatient facilities, but outpatient facilities also. I was just wondering if Medicaid outperforms Medicare reimbursement on an outpatient basis as well as inpatient. Thank you.
I don't have the statistics with me on if it's inpatient or outpatient. So let me go back and see if I can find you some and get those to you.
Representative Berquist.
I just have one question. Thank you. Thank you, Mr. Chair.
Representative Berquist.
Yes, I think you mentioned, Ms. Mays, 73,000 employees in Kansas hospitals. Is that the member hospitals or are they all members?
That would be all hospitals.
That's in all.
But they're almost all members for the most part.
Okay. Thank you.
Okay, I guess, committee, we've exhausted our questions, so very good. Thank you guys again for the presentation, very informative. We appreciate it very much. All right, next, a stranger to this committee, Rochelle Colombo. No, I'm just kidding. No stranger to this committee. But she'd feel bad if I didn't hang it on her.
I would. Good afternoon, Mr. Chairman, members of the committee. I see a lot of familiar faces and then some new people. And I want to say thank you very much for this opportunity to give just a kind of an informational background of who the Kansas Medical Society is and then what we do. And I do not have a slideshow or I don't have a PowerPoint, and we won't go in depth on all of our issues. I just wanted to give you a sense of who we are, and as the chairman indicated, I am often before this committee and always want to be available to you to answer any questions. I am Rochelle Colombo. I am the executive director of the Kansas Medical Society. We were formed 166 years ago in 1859 at the Eldridge Hotel. A group of pioneer physicians got together and said we need to form a society that protects patients and the practice of medicine. And our issues haven't changed that much in that amount of time. The healthcare landscape has changed vastly. There are a number of things that are difficult, but this committee, this very, very coveted committee that's after lunch that deals with the deep, deep divisions between the practices of medicine and the professionals that hold the privilege to have another life in their hands are before you. And we think it's critically important, and we really appreciate all of you serving on this committee. So welcome to the new members, and hello again to those of you that I have worked with before. So a little bit about who we are. We represent medical doctors and doctors of osteopathy, all of which have a 4-year undergraduate degree and then go on to medical school and then to 3 to 7 years of residency training. And after which they have an unlimited scope under the Board of Healing Arts, which oversees a number of professions, but physicians as well, and ensures that patients are protected in the care that they receive. So, some of the things that will come before this committee are scope of practice. We also work on liability issues and access and reimbursement. That was mentioned earlier. It was something that, as the chairman pointed out, we've worked on the last couple of years. We believe that access is critically important in Kansas. We have physicians that are serving all across the state in every single specialty. And we don't believe that quality and access should ever be pitted against each other. It's really important that all Kansans have access to the same quality of care. And we believe that the highest quality of care is a physician-led team. And so we support that. One of the things that has been a barrier to that has been the low Medicaid reimbursement rates. It hasn't been adjusted in a long time. It wasn't adjusted for more than 16 years prior to our coming in 2024 and asking for a 5% increase. The legislature granted a 3% increase in 2023, and a 9% increase in 2024. Unfortunately, that was not implemented. Although the legislature allocated those funds, KDHE did not implement those across the board. We believed that although some rates, higher impact rates, lower impact rates, they were all over the board, that all physicians needed to see an increase, as we have most physicians participating in the Medicaid program. But they limit it in their practice because, as was said, they're losing money on those patients. And so they have to figure out how to stay profitable, to be able to stay in practice to care for those patients. And unfortunately, KDHE did not implement a 9% across the board cut. Appropriation, even though that's what was allocated. We are still waiting on how that was implemented. It was applied as a percentage of Medicare. It has been stated that that was due to a rule and guidelines from the federal government, which we have not received. We believe it's critically important for you all, as well as the appropriators in the legislature, to know exactly what those rules are so that we can understand how they're impacting physicians, because they want to participate, they care about their patients, they want to take care of them, but they have to be able to afford to do so. And so we will be coming again this year and asking that the legislature again increase Medicaid reimbursement rates, and that the Department of Health and Environment be required to implement those increases as appropriated by the legislature. That is a huge part of participation. So we care very much about that. We think it's critically important. And the other thing I would say is there are about 5,000 physicians statewide that we represent, again, all specialties, and you'll hear from us on a variety of issues, but generally, we just believe that Kansans deserve the highest quality care, and that's why we're here. So I would be happy to stand for any questions on anything.
Committee questions? Representative Bueller.
Thanks, Rochelle. Thanks, Mr. Chairman. So refresh my memory. In 2023, do you have any of the rationale behind why those rate increases were not increased or implemented, so to speak? Because I don't recall that, and it's maybe my memory, but if you can help me, I'd appreciate it.
Well, that's a great question. And so again, we asked for a 5% increase in 2023. The legislature negotiated and got to a 3% increase. And I don't know that we were aware that it wasn't implemented that way in 2023 until in 2024, we got notice from the department that the 9% increase was applied to a formula based on Medicare. And we asked some questions about that. We met with the department. We're still awaiting answers based on, again, what is the federal guidance? Why was the legislature not made aware of that? Because there was a lot of deliberation around those issues, and it was not something that was brought before the legislature, nor was it brought to us. When we request an appropriation like that, we have to go to KDHE and say, okay, if this is the physician fee schedule and you do all codes, what would the cost be? And they provide those numbers to us. First of all physician codes were not included. They didn't include global codes, which would affect other providers, and because they're all based off the physician fee schedule. So they took some out and they didn't include them, and they received those funds. And it's important to also know that KDHE is able to adjust codes up and down without legislative authority. They can do that. But because they hadn't been adjusted since 2006, we said, you know what, it's time for us to go to the legislature and ask for a direct appropriation and to, create a law and a policy that says it's time to increase these. It was a very long time, and during that, there were cuts. That was during the time in which we moved to managed care. There were cuts for hospitals and physicians. Hospitals were restored, physicians were not. So they not only didn't get an increase, they got a cut. And we said, okay, so let's have the legislature do this. They did, and their answer still has been, we think there's a better way. We're going to look at a rate study, and we're going to apply this in a different manner, despite the law. It's been concerning for us because we're accountable to you. We don't come to you lightly and say, we want you to appropriate money and not know where it goes. During that time, after the special session this year, there were also other codes, non-physicians codes, that were increased. And that's fine. They have the opportunity to do that. But it's a question that we asked when the legislature was direct about how they wanted this money to be appropriated and that they wanted to make sure that providers were remaining in the network. Why wasn't it appropriated that way? And what should we ask for? We believe that physicians need to get another increase. We want to have a responsible ask, and we want those dollars to be appropriated, allocated, and implemented the way that you all intend to. So we have questions around that. We do plan to come before the Social Service Budget Committee and before Ways and Means and ask for another increase. We think it should be a systematic and over a course of time. We're not looking to break the bank. We know that the state has a lot of obligations, but if we care about that population, we have to keep providers in the network. And so we're saying, let's do this incrementally over time, and let's do it across the board so that we're not pitting different groups of physicians against one another. And we were disappointed that it wasn't implemented in that way. I don't have the answer to why it was not. I have the answer that I was given, but I have not seen the federal rule or the guideline which has been pointed to that allowed it to not be implemented that way.
Okay. Thank you. Thank you, Mr. Chair.
Committee, further questions? Representative Turner.
Thank you, Mr. Chair. Thanks for your presentation. I know you're a frequent visitor to this committee, and one of my learnings when I joined this committee is that we take up a lot of, I'll call them scope of practice or turf battles, because it is in statute in various places that says what type of medical provider, health provider can perform certain things. So as your guys were meeting at the Eldridge Hotel back years ago, there must have been other groups meeting too, because your group represents those, as you say, that go through 4 years of school, medical school, and then have a residency. Others, like ophthalmologist versus optometrist. So, or when we went through the nursing thing. So there's a board of nursing that regulates nurses, and I don't know how many others there are, right? Governing boards.
Correct.
Across the spectrum of medical providers. So just a few comments in terms of your view of how many of those there are, and what are the relationships between those boards in terms of communicating for the betterment of providing health care? Thank you. That's
a great question. They all have independent lanes. So you have a board of optometry, which is independent, and you have a board of dentistry. You have the board of nursing, which takes all of the different varieties of nurses, and then you have the board of healing arts, and I should know the number. I think it's around 15 different health professionals that they regulate, from physicians, PTs, PAs, I'm sorry, I shouldn't use acronyms, physician assistants, physical therapists, so many. There's so many under that board. And so kind of the breakdown, and in some in other states, they have a medical board which oversees all of them. In Kansas, they've been broken out. The Board of Healing Arts takes those folks that are generally trained in the medical model and that work under delegated authority under physician supervision, and we would welcome other groups to that board. We think it would be better because in the healthcare environment, when you go in to see a physician, you have a team that takes care of you. It's designed to work that way. There's a head of the team. Everybody on that team is critically important, but they serve in different roles. However, they should all be accountable to the same rules and regulations, especially if they are delivering medical care. So I say this in my testimony, and I'm sorry I skimmed over it. It's really critically important, so I'm glad that you asked this. The practice of medicine includes diagnosis, initiation of treatment and care, and the supervision of other medical care providers. So you're not born a doctor. Not everybody. I represent physicians, but I think they're special people, but they weren't born that way. They went to medical school, they got the training and education, and then they are regulated and held to a very specific standard. And we believe whether those acts are delegated or they're under the supervision of a physician, if you're delivering those acts, if you're holding the life of someone else in your hands, you should be held to the same standard. That includes education, training, licensure, oversight, and liability, right? So a patient should have an adequate right to recovery in the instance that you have an adverse outcome, whether through a provider fault or just something happened. A patient has a right to recovery. But we don't regulate all these things the same. And this is the bulk of what you all do in this committee is you say, okay, what does this profession do? What are they trained and educated to do? Who's regulating them? And what are the rules for them? And it's, it gets called turf battles. It is scope of practice. What is the scope that they are allowed to do? Physicians are not limited in scope. They have the highest training and education. They are not limited. They are allowed to do anything within that scope of diagnosis, initiation of treatment, and medicine and surgery. They are the only ones who are allowed to do that unsupervised and under the Board of Healing Arts. There are others who are allowed to do delegated medical acts and who are allowed to do those things under the supervision of a physician, even under a different regulatory board. They don't necessarily overlap. The Board of Nursing is independent. They regulate nurses, and even though they now have the ability to prescribe and order durable medical equipment, which is a portion of the practice of medicine, they remain under the Board of Nursing. So those are the issues that we feel are critically important. And even though they get called turf battles, I would argue it's not a competitiveness issue, it's a quality issue. And all of these people are important. We want everybody on the team. We just want everyone to be in their lane and to be regulated in a way that protects the public. So that's our position and where we come at these things philosophically. And yes, you'll see me frequently because that's what we do. Everybody is looking for changes in the law that reflect changes in education or changes in potential scope. But we feel strongly if those changes are granted, then the public has to be protected with fair and equal rules.
Thank you, and thank you, Mr. Chair.
Mr. Bryce.
Thank you, Mr. Chairman. Thank you, Ms. Colombo. It's great to see you. I have a very broad question, but I'm just curious as to how you might respond to it. We're seeing a lot of changes in Washington, D.C., federal government level, whether it's Office of Government Efficiency, RFK Jr. may be influencing healthcare in the near future. I was just wondering on a broad scale, whether it's scope of practice or reimbursement, how do you see the threats or the opportunities in the state of Kansas for healthcare in light of the changes happening in Washington? Thank you.
Well, that is a very broad question. I think it's a great question. There's obviously, with any of these changes, there's opportunity and there's going to be difficulty in transition. I think the number one challenge that we have in Kansas is, first of all, let me say this. We have a wonderful climate to practice medicine. We have a wonderful climate to receive care. We have wonderful physicians here. We have a great liability climate, which protects patients and makes it advantageous for physicians to want to locate in Kansas. We have great reimbursement programs through the KU School of Medicine. So there are a lot of reasons for physicians to want to practice here. The reimbursement rate is not a threat to physicians. It's a threat to patients. If we want to make sure that Medicaid patients have access to quality care, then we have to address that. So I think that's the biggest challenge that we have because, again, we're a small state where people are connected to their patients and want to provide that, but they're limited because they're squeezed so hard. You heard Ms. Mays talk about prior authorization. It's a huge issue. It's a huge barrier to care. You have physicians that are saying, we know what you need. This is the care you need. It's timely, and they're being denied. It's a problem, and it's been a problem for a very long time, and we should get the bureaucracy out of the way, and we should let patients get the care that they need that is covered by their insurance. That's a threat. Medicaid reimbursement is a threat. I don't think scope of practice is a threat. I think that's just a normal evolution of professions and the legislature, and that's what you all are here to do. And so I appreciate you deliberating these things. Opportunities. you know, I couldn't even begin to guess what we're going to get from the federal level on those issues. We're going to get some restrictions and, you know, and maybe those things will yield good things. I don't see those things being problems for physicians. They're going to do what they believe is standard of care, and they're going to be held to that standard. And so I don't think they worry so much about that. It's just, can they continue to care for their patients in the best way they know how?
Any further questions? Okay, you're off the hook.
Thank you.
Very good.
See you soon.
Okay, very good, committee. Thank you for the vigorous questioning. And with that, we're adjourned. Oh, sorry. I didn't look at my agenda. Okay, next we have Chuck. Chuck, thank you for coming. I'm sorry about that. About ran you out the door there. So, very good.
Matt, I'm the Speaker Pro Tem of Silverhead Legislature. In your information, and I'll try to be concise, in the information tells you a little bit about Silverhead Legislature. I don't know how much you know, but we are volunteer people. None of us get paid, and we are elected in the areas of the 11 area agencies on aging to represent citizens of Kansas 60 and older. And one of the major things we do every year is we have an actual legislative session right here in the Capitol in October of every year. We have a 3-day session, and our charge is to come up with the issues that we need to advocate for older Kansans that will make life better for them. And so in the interest of brevity, I will just go right to those issues. It's been traditional that we have presented that to this committee, even though many times these issues don't particularly pertain to this committee. There are 5 resolutions that we passed. First off was a resolution urging the legislature to establish a medical cannabis advisory board to explore and make recommendations regarding the expanded medical use of cannabis. This is something that's been on the dock for a while. 39 states have medical cannabis, and it might, to some people, it's surprising coming from a senior group, but in actuality, it's mostly people 50 and older that use this. And we're talking about medical cannabis. And oftentimes people get confused with the recreational cannabis. We're not talking about that. We want a well-regulated, prescription-based type of program that would be prescribed from pharmacies and of course, prescribed by doctors and then filled by pharmacies. So we would like to get the process started by establishing an advisory board to do that. Second resolution was to urge the legislature to support the expansion of Medicaid in Kansas. And you might think that sounds kind of strange from an older group because you've got Medicare. We represent about 670,000 Kansans from the age of 60 and over, and there are about 14,000 between that age of 60 and 65 who could benefit from the expansion of Medicaid. Besides that, many of the people who could benefit from Medicaid expansion are people who are healthcare workers working in homes with elderly people and fit in that, they're in that gap that doesn't qualify for Medicaid. And then lastly, you just saw from the Kansas Hospital Association, 67% of the hospitals in Kansas are at risk. And that would provide more revenue to those hospitals. That doesn't solve the problem, but it certainly would be a help. And the location and the availability of those hospitals to elderly is more important than to any other age group. Third resolution was to urge the legislature to enact legislation converting CAPERS, Kansas Public Employee Retirement System, Tier 3 to Tier 2, and then provide a COLA for the Tier 1 and 2. We realize this is a very expensive process. We also realize that it is not the people who are members of CAPERS who have caused the shortfall that we currently have in CAPERS. It's a result of the state not funding over a number of decades. And so what's happened, and we're talking about people, we're not talking about necessarily, and we understand the cost of this, and there'll have to be some restrictions. But the people who were custodians, who were bus drivers, who were paras, have not had a COLA since 1998. They have not had an adjustment to what they're making. And we think that's it's time to do that. Plus the Tier 3, many of you may be on Tier 3 if you started in CAPERS after January 1st of 2015. And I think anyone who studies that realizes Tier 3 is not a very good retirement system. The next resolution was to urge the legislature to increase the current funding for the Senior Care Act to meet rising costs of services and growth of the aging population requiring those services while keeping current statutory eligibility requirements. The Senior Care Act provides for things like home modifications, home care, that sort of thing that is so important to seniors to stay in their homes. And we all know it's much more cost effective to be in their own homes, and that's where most seniors want to live. And if they can have those services, it's much better. We appreciate about, I think it was in 1923, there was or 1922, I believe, there was a $3 million increase in that, but we think it's time for another. And I know KDADS has put a $5 million proposal increase in their budget. By the way, those home care issues are by ability to pay. So it's not for people who can afford it. It's for those who can't afford it and would still be able to stay in their homes. I have a 92-year-old mother-in-law whom I look in on and help out with, and she can afford it. She has home care coming in daily, but not everybody can afford that, and that's what this would help with. And then finally, a resolution urging the legislature to continue supporting and funding collaborative community-based transportation to senior citizens. As you can imagine, transportation is a huge factor, and particularly in more rural areas. There are some counties and cities that provide types of transportation for elderly, but not enough. And we would like to expand that, and we would like to work with the Department of Transportation to do a better job with that. So with that, I will end my remarks, and I'll stand for questions.
Very good. Committee questions of the silver-haired legislature. And Chuck.
Thank you.
Seeing none, thank you very much for coming. Okay, I need to look at my agenda a little more often, committee. I was about ready to adjourn the meeting. Okay, committee, anything else? We are adjourned.